Ladies and gentlemen, it is time for the commencement of session 2A of oral presentations.
Presiding over this session will be our chairperson and judge, Dr. Krishna Pradeep and Dr. Kaushika. Mr. Kasun will be joining us as the timer.
Before we commence the session, we would like to remind the presenters of the following. Each of you will have 7 minutes to present your research. At the end of your time, you will have a Q&A session of 3 minutes. The total time allocated per presenter, therefore, is 10 minutes. There will be 1 bell ring at the end of 5 minutes and 2 bells ring at the end of 7 minutes.
With that being said, let us warmly welcome our first speaker for this session, Mr. Senanayaka, BPD, to present their research on parental knowledge on allergy and anaphylaxis, a multi-center study.
Good afternoon, all of you. I am Assistant Research Engineer from Research Group 33, and our research topic was parental knowledge on allergy and anaphylaxis, a multi-center study. So let's get into some background knowledge about our research topic. And allergy is an IgE-mediated type 1 hypersensitivity reaction triggered by allergens. Common allergens are food, drugs, plasters, insects, and airborne allergens. Anaphylaxis is the most severe form of the allergy that triggered by the previously sensitized allergens, and it is a critical, rapid progression systemic hypersensitivity reaction that can cause fatal outcomes. And the allergy and anaphylactic reactions can happen in people irrespective of their age, and to avoid the fatal outcomes, in children, parental knowledge about the allergens, symptoms, as well as management is important. So we found some gaps in knowledge about this topic in Sri Lankan studies. That's why we implement this research on this topic. This is our general objective. So to assess the parental level of knowledge about the allergy and anaphylactic reactions among children and its association with socio-demographic status like age, gender, and education status, recruiting parents attending 3 tertiary care hospitals in Kandy, which were Sirmawa Bandaranaga Children's Hospital, National Hospital Kandy, and the Teaching Hospital Peradeniya. In the methods, this was a descriptive cross-sectional study, and we made a proposal and got the ethical clearance from the Ethics Review Committee. And our study sample was 384 parents attending main 3 tertiary hospitals in Kandy, and the inclusion criteria was parents that visited the above three hospitals, and their children must be under 18 years of age, and also parents must have enough literacy to read, understand, and then write answers to these questionnaires. And we excluded the parents of severely ill and mentally retarded children. So in our research, we did not limit our study to just affected children's parents. We included the whole parents. As we couldn't find a validated standard questionnaire from previous study, we made a questionnaire on ourselves, and it was a self-administered questionnaire in all 3 languages, Sinhala, English, and Tamil, and it included questions about the allergens as well as the allergens like common allergens like food, drugs, plasters, airborne and insect venoms, and also signs and symptoms, and the initial management. And we put a special part about the adrenaline auto-injector, AAIs, to check the knowledge on it. So these were our variables. The independent variables were the socio-demographic factors like age, gender, and the educational status. Dependent variables were level of knowledge about common allergens, about the signs and symptoms, as well as the initial management. In the results, in the first table, the socio-demographic results, in the first table you can see the majority of parents were from the age group 36 to 40 cohort. It was around 29% of the whole sample. In the second table, majority of the people were females, it was around 80%. And regarding the education status, most of them educated up to A levels. So out of the all parents, there were 36 parents whose children had any type of allergy, which is around 9.4%. When we assessed the knowledge about the adrenaline auto-injectors or the AAIs, we found that only 4 parents knew about the AAIs. Out of these 4, only 1 parent knew about how to use it and they are to use it, these auto-injectors. So as this is a self-made questionnaire and we use the cutoff marks as 50% to analyze the whether the knowledge was satisfactory or not. As you can see, only 14.8 parents had the total marks more than 50%, which is satisfactory. As we mentioned in our objectives, we assess the association between the independent and dependent variables. So using chi-square test, we analyze our data to check the association between these 2 factors. So in this chart, you can see the association between the age and level of knowledge, and its p-value is more than 0.05. So this association is not statistically significant. In this chart, we assess the level of knowledge, we assess the association between level of knowledge and the gender, and here also the p-value is more than 0.05. So this chart also, this correlation is not also statistically significant. When we assess the association between the level of knowledge and the education status, the p-value is more than less than 0.05, and we found that there is association between these 2 parameters. As a conclusion, this study highlights a lack of knowledge among the parents regarding allergy and anaphylactic reactions in children, and most of the parents ignore minor allergic reactions which can end up in fatal outcomes. Most of the parents use non-scientific home remedies for allergic reactions, and majority of parents have never heard of adrenaline auto-injectors. We recommend some interventions such as introducing awareness programs about allergy and anaphylaxis in hospitals, MOHs and the society levels, and also we like to introduce adrenaline auto-injectors to the Sri Lankan setup, and further research studies are recommended to evaluate each type of allergens because we assess the all the most common type of allergen like food, drugs, classes like. So, and we also recommend some research studies to evaluate the validity of home remedies that people use in allergy management. So we had some limitations. We didn't compare the level of knowledge between affected parents and the unaffected parents, and also the answers we got correct were ones from the previous literatures. However, there can be exceptional answers rather than which we got as correct. And since we didn't have similar previous studies, we used the cutoff point as 15. It was an expert-derived cutoff point, and to say the satisfactory or not. But with the associated factors, that cutoff point may change. These were our references, some of our references, and we'd like to thank our supervisor, Dr. Keethy Saranaika, as well as the Dean of the Faculty of Medicine, and the parents who participated in this research project. Thank you.
Thank you, Mr. Sennaika, for that study and presentation. Now, what made you to develop this research idea? What was the thought process behind that?
So in the recent past, there was multiple cases about anaphylaxis and multiple deaths around in the country. That's why we did this research, and most of the researchers were about the affected parents, whether the food allergy or the drug allergy. We did this research for the whole population to see whether they have knowledge about these allergens, symptoms, and the initial management, what to do when allergic reactions happen, and that's why we choose these topics.
Yeah. Now you had a sample size of 300 or no?
300.
So how did you calculate? How did you come to that number?
Yeah, according to the standard questionnaire, Cochrane's formula, we got the number as 384. We didn't add the dropouts because we didn't follow up these patients, so we didn't add the dropouts. That's why we got the number as 384.
You said you did not have a validated questionnaire. Then you prepared a question. Did you do sort of a pilot study in a small group to validate it?
Yes, so we did a pilot study to validate from getting 20 parents before the study, but we did a mistake. We did our pilot study in the teaching hospital here because our sample was from the teaching hospital. It was a mistake, but we did the pilot studies.
Right. And how many questions were there in your questionnaire?
22 questions.
Right. So what sort of questions did you ask about anaphylaxis in that questionnaire?
Initial parts, we had some questions about social demographic factors. Then the common food allergens.
Yeah.
What are the types of food allergens that you know, drug allergens as like that.
Yeah, no, but I am asking now regarding knowledge. So did you use a Likert scale or yes/no answer? What sort of question and what sort of answer?
We used, most of them were open-ended questions. We asked about the symptoms according to the systems, like what are the symptoms that you can see in the cardiovascular system, then the respiratory system. Likewise, we asked them like that.
It's open-ended question.
Yeah.
So in your limitations, you have mentioned that you didn't compare the knowledge of the parents who had children with allergies and who didn't have. You said that in your cohort there were about 20 parents who had children with allergies, isn't it? About
9.4%.
9.4%. So you all didn't deliberately check on that, or did you all see a difference when you are looking at the results? Do you see any difference between the knowledge in those patients, or what made you? So you could have calculated though it was a small percentage, you could have seen the knowledge. What made you not see that factor?
So we got the whole population, and out of that whole population, 9.4% parents said that their children had any type of allergy. They have said whether food allergy or drug allergy, most of them. They haven't specifically say what's the allergy. We asked about the cross-sector question with the if your children, do your children have any kind of allergy? Yes or no? That's why I said.
And regarding the use of adrenaline automated did you only about very minority of the people knew about it? Did you see about the education level, and were you able to compare that? You have broken down into the education level. Was there any association between because they were in which cohort they belong to?
Only one person knew about the how to use that adrenaline auto injectors, and he was a pharmacist.
Right. Okay. Thank you.
Thank you. Next up, we would like to invite Ms. Kimhani AJ, who will be delivering their presentation on parental awareness of diabetic ketoacidosis and hypoglycemia in children with type 1 diabetes mellitus attending a children's hospital.
Good afternoon, everybody. I am AJ Kimhani from Research Group 12, and our title is Parental Awareness on Diabetic Ketoacidosis and Hypoglycemia in Children with Type 1 Diabetes Mellitus attending the Children's Hospital. When moving on to the introduction, Type 1 Diabetes Mellitus is an autoimmune disorder leading to absolute insulin deficiency. The suboptimal management of Type 1 Diabetes Mellitus can result in short-term and long-term complications, with diabetic ketoacidosis and hypoglycemia being the most common. Parental awareness is a crucial determinant factor in the prevention and timely management of these complications. And our main objective is to assess the level of parental awareness on diabetic ketoacidosis and hypoglycemia in children with type 1 diabetes mellitus attending a children's hospital. When moving on to the methodology, this is a descriptive cross-sectional study of 210 parents, guardians of the children below 15 years of age diagnosed with type 1 diabetes mellitus in pediatric endocrine clinic at Simao Bandaranaike Specialized Children's Hospital, Peradeniya. This study was conducted via a self-administered printed questionnaire with Sinhala and Tamil languages with close-ended questions. And the data collection tools we used for the DKA questionnaire was a validated questionnaire used in a previous study in Hale region of Saudi Arabia. And the hypoglycemia questionnaire is a standard modified Golden-Clark questionnaire. And the data analysis, the response database was created in Microsoft Excel 2007 and analyzed using statistical package for social science. The contingency tables were used to characterize the participants' socio-demographic details. Mean, standard deviation and range were used to describe the continuous variables. The independent sample t-tests were used to compare knowledge across sex and age groups. This association between knowledge and the socio-demographic data were found using one-way ANOVA and post-hoc Tuckey test. And this is the results of the socio-demographic characteristics of the participants. And as a result of highlights of the results, out of 210 questionnaires, 100 were fathers and 110 were mothers. And among them, all fathers were employed and about 76.2% of mothers were unemployed. And more than half of them has more than 40,000 monthly income, and 11.9% had less than 20,000 monthly income. And all the parents were legally married, and no single parents or divorcees were there. And when going to the awareness level of DKA, the parents were categorized as having poor awareness if they had obtained a score below 50, and moderate awareness if their score was between 50 to 75%, and good awareness if they obtained a score above 75%. This is a standard, we use this from a standard questionnaire in the Hale region. And according to the results, 82.38% has a poor awareness level and 4.28% had a moderate awareness, and 13.33% has a good awareness. And the awareness level for hypoglycemia, 93.8% scored more than 50% in the questionnaire, and 6.19% scored less than 50% in our questionnaire. And this is the parental awareness on DKA of the questions we asked in our DKA questionnaire. And here, as you all can see, more than 80% doesn't know that DKA is an emergency, and it can occur due to missing insulin and occur due to irregular exercise and diet, and maintaining normal HbA1c reduces the risk of occurring DKA. And 68.1% even doesn't know that their child has ever experienced a DKA episode. And here this shows the awareness about the symptoms of the DKA, and as you can see, those symptoms are identified only by 15 to 17% of the participants. And this is the parental awareness on hypoglycemia. Here you can see that more than 90% knew that this is an emergency and that needs urgent treatment and can be treated at home and occurs after missing meals and taking insulin. And should give a sugary drink after following a hypoglycemic episode. And 39% knew that maintaining normal HbA1c level reduces the incidence. And this shows the awareness on hypoglycemic symptoms, and about 80 to 90% participants identify those as hypoglycemic symptoms. And this slide shows the sources of knowledge about DKA and hypoglycemia in parents. It is mostly from the consultants, followed by clinical staff, booklets, and social media. And when talking about the associations, there were knowing association between the parental awareness with the parental awareness of DKA and hypoglycemia with the socio-demographic data. And going on to the discussion, parental awareness on detection and home management of hypoglycemia was satisfactory. The primary source of information happens to be the consultant, and the input from other healthcare members is also significantly high. The gathered data has demonstrated that the knowledge of caregiver on diabetic ketoacidosis is very unsatisfactory, so there is a compelling reason to bridge the gaps in the awareness of DKA among the caregivers. And we recommend that further studies from pediatric diabetic clinics in other parts of the country are of significant importance to establish the parental awareness on their child's illnesses, and steps to be taken to improve the parental awareness on the diabetic emergencies and home-based treatment. And healthcare professionals need to be involved more in providing health education to the parents and the children, and parents should be provided a clear guidance on how to manage diabetes during the DKA episodes to avoid the harmful complications of ketoacidosis, uncontrolled or symptomatic hypoglycemia, dehydration, sustainable administration of insulin. And we would like to thank all the parents and caregivers who participate in this research and made this study possible. And also special thanks to Professor Vasanthi Pinto, Dean of Faculty of Medicine, and our sincere thanks to Dr. A.M.S. Veera Bandara, the Director General of Sirumava Bandaranayake Hospital, and Dr. Janani Sundaresan, this consultant pediatric endocrinologist of Sirumava Bandaranayake Hospital, Peradeni. And these are some of our references, and thank you.
Thank you, Gimhani, for that wonderful presentation. Few questions. Now, what made you to study this research topic?
Actually, this is we discussed among our group members, and since there were no any local literature about this topic, and there wasn't any single similar study done in Sri Lanka, so we thought of doing this, and then we can show any results, and then we can implement something to the society to.
So there's no single study on parental awareness on diabetes in Sri Lanka.
No.
Okay. Right. Now you said you used a questionnaire which was used in a study in Saudi Arabia, then translated it, isn't it? So did you do the cultural adaptation and language adaptation before using it, or just the direct translation?
We translated it, and then we just we did a pre-test among 20 participants, and then we adjust some we adjust complex words to simple words, and then we.
Yeah. So in your question, for example, for the word diabetic ketoacidosis, what did you use in the translation?
Yeah,
You use the same word, or did you do a Tamil Sinhala translation for that word?
Tamil and Sinhala.
Yeah, what is the word did you use?
Sinhala one, we use that keto amlikata.
Yeah, so same in Tamil as well.
Yeah.
Okay. And now there can be patients who have been diagnosed for 15 years. There can be patients who are diagnosed for 5 months. So their parental knowledge might differ. Did you compare that and see?
We asked the age of the child, and then in our study, the study was for the included that below 15 years of age, and then we asked what is the age of the child also, but we didn't compare that the age and with age of the
diagnosed years.
Yeah,
so that will have a significant difference on the knowledge, isn't it? That's, yeah. Now, so you said you did this study in Sirumava Bandaranayake, and you have found out there's a gap in the knowledge. So what's your plan from here onwards?
Yeah, we would like to implement any awareness programs in the clinics by.
So rather, would you like to give feedback to the consultant there?
Yeah. We would like to give an feedback to the consultant and arrange some leaflet distribution in the clinics in the DK.
Right. Thanks, Gimani. Thank you.
Thank you.
Thank you. Ladies and gentlemen, please welcome our next presenter, Ms. Kanshika K, to present their research on social, psychological and financial burden on caregivers of children with chronic kidney disease, a cross-sectional study.
Good afternoon, everyone. I am Kamsika from Group 18. I am here to present a presentation about social, psychological and financial burden on caregivers of children with chronic kidney disease, a cross-sectional study. What is CKD? We all know it's chronic kidney disease. and it's defined as persistent presence of structural or functional kidney abnormalities for a minimum of 3 months. Caregivers of children with CKD face a significant psychological, social and financial burden more than a normal population. This study evaluates these burdens among caregivers of children with CKD. By assessing and comparing the extent of burden between various stages of CKD, we can help them and optimize the outcome of the disease. By evaluation of the burden, we can arrange supportive counseling programs according to the emotional needs and knowledge requirements. Our research may help to identify the caregivers who need financial support and help them to get support from building welfare organizations. Our objectives were to assess psychological burden experienced by caregivers of children with CKD by using modified PHQ-9 and DIABETIC questionnaire, to assess the financial and social burden by using modified family burden interview schedule, to compare the caregiver burden between according to the treatment modalities like pre-dialysis and dialysis groups of participants. Our study setting was professorial pediatric clinic, teaching hospital Peradeniya. Our participants were caregivers of children with hemodialysis, peritoneal dialysis, or CKD stage 3, 4 and 5. We collected data from 97 caregivers and we used to assess social and financial burden, family burden interview scale, and to assess psychological well-being, DIABETIC and PHQ-9 questionnaires were used. Analysis done by ANOVA, post-hoc and child scale test. When we see our participants, there are 75 female participants and 22 male participants. When we categorize our participants according to the CKD stage, there are 21 in CKD stage 5, 46 under stage 4, 25 in stage 3. Then we further divide our participants according to the treatment modality. There are 67 participants who received dialysis type of treatment and 30 participants who received other treatment modalities rather than dialysis treatment. According to the educational qualification of the parents, there are 63 participants who studied up to secondary level of education and 23 up to advanced level and 11 who completed a degree or diploma at least. We assessed psychological burden as to depression and anxiety. Depression was assessed by PHQ-9 score system. It's commendable that 34% of our participants experienced severe depression. And when we further analyzed by ANOVA test, it showed that there is no significant correlation between CKD stage or the mode of treatment or gender or educational qualification with the depression score. Then we moved to anxiety. It was assessed by DIABETIC score. 46.8% of our participants, which is the most number of our participants, experienced a moderate level of anxiety. And in the ANOVA, we found out that the CKD stage significantly correlated with the level of anxiety, and stage 5 has experienced more anxiety than stage 2, 3 and 4. Then the treatment modalities and gender or educational qualification do not have significant influence on the severity of anxiety. When we move to social burden, it was assessed by family burden interview scale. It's commendable that 45.7% of our participants experienced moderate level of social burden. And we analyzed, it came as the CKD stage and the mode of treatment has significant correlation with the social burden. Then we further analyzed it the post-hoc. It showed stage 5 faced significant higher burden than stage 2 and 3, and also dialysis group patients experienced more burden than pre-dialysis group. And here also gender and educational qualification do not influence the severity. When we assess financial burden, we can see from a mean score of our burden, the financial burden after the diagnosis dramatically increased after the diagnosis of the CKD. In this table, we can can see with increase of the stage, the mean score of burden also get increases and is highest in CKD stage 5. When we perform our analysis, it shows that CKD stage and the treatment modality has significant correlation with the financial burden. Here also, stage 5 experienced more burden than 2 and 3, and also the dialysis group experienced more burden. Here, gender and education do not have significant influence on the severity. As a conclusion, we found out that CKD stage has a significant impact on the anxiety, social and post-diagnosis financial burden experienced by our caregivers. The most significant experienced by caregivers of children with CKD stage 5. Caregivers of dialysis group children bear greater social and financial burden compared to pre-dialysis group, and gender and educational qualification do not significantly affect the various burdens analyzed in our study. As a limitation, the sample size, we only collected 97 participants in a given duration. It would be better if we were able to collect more than this. And the data collection has a lot of questions, and it was time consuming, and parents are reluctant to fill that. And there's a recall bias because the CKD was diagnosed long way before, so they can't remember everything accurately. Our recommendations are to develop supportive programs from our study in the clinics or in the wards according to our findings. And we recommend to do further research to better understand and alleviate caregiver burden by conducting the study with more sample size and with a longitudinal study. Thank you.
Thank you, Kamsika, for the presentation. So what made you select this topic and how did you all get this idea?
As a group, we discussed the way file and we thought about to do a cross-sectional study because we had only 2 weeks of data collection period. Then we discussed it, and also we talked about assess any chronic disease with the psychological, social and financial burden in any chronic disease. Then it's easy, we had a supervisor with, who is professor in pediatric nephrology. So we selected this.
So this questionnaire, was it like was an interview administered questionnaire or?
Yes, sir. We printed out the questionnaire and translated it in both languages, and we distributed among them. If they can fill, they filled and gave it to us. If they can't fill, we asked them to be filled.
So you all helped out with the filling if they can't fill. Did you all check for the correlation between the duration of the disease and these factors, psychological impact, anxiety?
No, sir. We didn't consider.
And also, can you elaborate on this PH29 and GAD7, those questionnaires that you are, what are they? And can you mention?
They are standard questionnaires which is from WHO to assess anxiety and depression. So we use.
Was the full form of the questionnaire used? Or?
There are 7 questions in GAD7 questionnaire and 9 questions in PH9 questions.
Right. So all 9 questions were asked.
What does it mean GAD7 and PHQ? What is the full form?
Generalized anxiety.
Other one PHQ?
Public.
And you said the impact was more on stage 5. Were there any reasons, particular reasons you found out?
Because they need to come to the hospital and need to admit frequently for the treatment because of the severity of the
And the dialysis, frequency of dialysis, they come twice a week or so, isn't it? Thank you.
Thank you, sir.
Thank you. Our next presenter, Ms. Kolaratna WTD, will now present their research on knowledge and attitude regarding childhood vaccination in a sample of mothers in Kandy district. The floor is yours now.
Good afternoon, everyone. So our research was on the knowledge and attitude regarding childhood vaccination in a sample of mothers in the Kandy district. Now, immunization is a highly effective method of protecting humans from infectious diseases, and is especially important for infants and children who are the most vulnerable against these diseases. And as mothers are the primary caregivers of their children, it is important to evaluate their understanding on this subject. This brings us to the general objective, which was to assess the knowledge and attitude of mothers regarding childhood vaccination program in the Kandy district of Sri Lanka. Besides those, in our specific objectives, we sought to describe the factors associated with the knowledge and attitude, and we also sought to identify the sources of information about the National Childhood Immunization Program. Now, the study that we carried out was a cross-sectional descriptive study. It was carried out in Teaching Hospital Peradeniya, National Hospital Kandy, as well as the Sima Bandaranayake Specialized Children's Hospital Peradeniya. So we included the prenatal and postnatal mothers from the obstetrics and gynecology wards, as well as the mothers who were present as bystanders in the pediatric wards. So they all fulfill the criteria of having one child under the age of 12 at the very least, and had been residing in Kandy for the past 3 years. The minimum sample size we calculated was 189, and through convenient sampling, we managed to include 200 in our study. So we used a researcher-administered questionnaire for our data collection, and it was composed of 3 parts. The first on socio-demographic data, second on the knowledge, and third on the attitude and the information sources. So following ethical approval, we collected the data and we analyzed it. So the categorical variables were represented as percentages, and the numerical data was represented as mean. For further analysis, we calculated knowledge scores and attitude scores, and to find associations between these scores and the socio-demographic data, we used Pearson's chi-square test and Fisher's exact test, as well as the post hoc test. So this was all done using Microsoft Excel and SPSS version 26. Now, as you can see, in our sample size of 200, the majority of the mothers were in the age group of 30 to 40 years. About 41%, that is the majority, had been educated up to advanced levels. The majority were also Sinhalese in ethnicity, and more than half, that is 51%, had a maximum of 2 children in the family. So this is the distribution of the knowledge score, and as you can see, the mean score that was achieved by our participants was 68.58%. And this is the descriptive data pertaining to our questions on knowledge, and from these we deduced the majority had a very good awareness on the names of vaccines that were included in the extended program of immunization, as well as the schedule pertaining to it. But the specific knowledge was actually quite poor. As you can see, only 13.5% knew that the BCG vaccine was administered to prevent tuberculosis. Now, the attitude was measured using 14 statements, and the response options ranged from strongly agree to strongly disagree, with the highest achievable score being 70. The mean score was 64.25, and 98% of our mothers actually had a very positive score. Now, most of our attitude statements had a positive response from more than 85% of the sample, but there was this one statement that got a comparatively negative attitude, and that statement was that vaccines administered in the private sector are much better than those given in the government sector. Moving on to the information sources, the majority stated that medical workers, and that is mainly the public health midwives, were their source of information. And in a world where technology is quite abundant, it is surprising to see that only 31% browsed the internet to search about immunization for themselves. And regarding associations, the education level, ethnicity, and monthly income showed a significant association with the knowledge. For attitude, of course, only monthly income showed a significant association. Now, in our discussion, there is one point I want to bring out, and that is that in our study, we concluded that the majority of the mothers had an average knowledge score. But in studies done in central Sri Lanka and southern Sri Lanka, they deemed that their participants actually had a very poor score. Now, this contradiction stems from the difference in our questionnaires. So their questionnaires included quite specific questions such as the age of administration of each dose of vaccine, as well as the disease prevented by each vaccine. Whereas we inquired on the specifics only about the BCG vaccine and the oral polio vaccine. So through this difference, we can actually come to the hypothesis that in general the mothers are very diligent about the ages, that is the vaccination schedule of the extended program of immunization, but have a very poor understanding on the specifics or deeper knowledge regarding immunization. For example, only less than 50% were aware that the pain-tolerant and ADT vaccines, that they were included in this immunization program. And of course, the knowledge about the vaccines administered at the ages of 11 and 12 years was actually quite poor. Another point that we found through an open-ended question was that 16.5% of the participants believed that immunization can cause infertility late in life. Now, this is worrying because this result tallies with a study done in Nigeria in 2010. I'm sorry, not 2014. But a recent study in Nigeria states that this rate has dropped to 0.9%. And considering the attitudes, so the vast majority had a very positive attitude, and this is very much in line with other studies done in Sri Lanka. Another interesting statement was that 9% of the mothers stated that and this was a negative attitude, stated that they would not recommend vaccines to others. And when we inquired on why that is, it is because they believe that they did not have the right or the proper knowledge to recommend immunization to others, and that it was solely the responsibility of the healthcare workers. And of course, there's a significant association with the education level and the monthly income. This is quite inconsistent with other studies done throughout the world, although there are some other contrary studies. So our major recommendations is that in each routine clinic visit, mothers should be educated about immunization, and more than that, they should be encouraged to search and learn about these diseases for themselves. And any misconceptions they have should always be resolved by healthcare workers through health promotion activities. These are my references. I would like to acknowledge all those mentioned in this slide. Thank you very much.
Thank you, Ms. Kurat, on that excellent presentation. So what made you select this topic for your research?
Most of us were actually very interested in this vaccine hesitancy. So starting from that and discussing amongst ourselves, we came up with several topics regarding vaccination, and this was the one we finally settled on. For example, there's a lot of, with the COVID vaccine, there was a lot of talk about vaccine hesitancy, and we kind of wanted to see how whether it has had an effect on the extended program of immunization. And with that, we just related it to the mother's immunization on this subject.
So there are vaccines which are given under the EPI program, and there are non-EPI vaccines as well. So did you have a question about the non-EPI vaccines as well? Or?
No, sir. It didn't.
So the questionnaire, was it, did you all develop a questionnaire, or did you do the study based on a different question?
It was, so we went through multiple questionnaires that were done in other studies throughout the world, and using those we compiled our own questionnaire, but then most of it was actually from a study done in Sri Lanka, actually, in the central Sri Lanka.
Yeah. And now you said there were similar studies done. So were there any studies done in KANDY before?
Yes, sir. In the KANDY district, in central Sri Lanka in 2018. It was done at not in a hospital setting. It was done in a
Okay, that's
what.
what.
I believe.
Yeah. So now you said with you the title is childhood vaccination. So did all your questions cover all the vaccines?
So asking specifics about all the vaccines, The initial questionnaire we compiled had those questions, and that took quite a lot of time to get through. So we decided that the BCG and oral polio vaccines were things that people have heard about, so we focused on those.
Those
And
two.
just asked about the awareness of the others.
Right. Thank you.
Thank you very much, sir.
Thank you. Our final presenter for this session is Mr. Netsara SJH, who will be delivering the presentation on assessing asthma control and associated risk factors among children with asthma presented to tertiary care hospitals in Kandy district.
Good afternoon, everyone. I am Hibushan Etsura, a fourth year undergraduate of Faculty of Medicine, University of Pennsylvania. Here today to take you through our study titled as Assessing Asthma Control and Associated Risk Factors Among Children with Asthma presented to tertiary care hospitals in Kandy district. So, as we are dealing with the disease of asthma here, let's have a brief introduction for the disease. So, asthma is a heterogeneous disease characterized by chronic airway inflammation, and it is defined by the history of following respiratory symptoms: wheezing, shortness of breath, chest tightness, and cough. So, let's focus on some known facts about asthma. So, asthma is a chronic disease with a considerable defect on pediatric population. So, as it is obviously can be understood, well-controlled asthma improves the quality of life of suffering children. So, how we can control this? Yeah, we have to focus on the associated risk factors of asthma. To tackle those risk factors, then we will be able to optimally regularize those risk factors, and it will definitely lead to a good asthma control. So, with those in mind, our general objective of this study was to evaluate the level of asthma control and associated risk factors among children with asthma presented to tertiary care hospitals in Kandy district. So, regarding the specific objectives, we had three. So, first one was to find out the number of patients with well-controlled and poorly controlled asthma. Then, to assess the demographic, socioeconomic, environmental, and treatment-associated risk factors connected with childhood asthma. The final one was to determine the differences of risk factors between well-controlled and poorly controlled groups of children presented with asthma. So, how did we do this? Yeah. So, first we assess the asthma control level. For this purpose, we use the Childhood Asthma Control Test, which is widely known as CACT. This is based on GINA guidelines, and it assesses limitation of activities, cough, awakenings at night due to asthma, and finally, the daytime symptoms. So, if I little bit elaborate on CACT, it consists of 7 questions, 4 asked from the child and 3 asked from the parent. A maximum score a child can score in this particular question is 27, while the lowest being 0. If a child scores more than 90, we consider those children to be having a good asthma control. So the next step of our methodology to assess the associated risk factors. So we went through a thorough literature survey, and we could find a long list of risk factors associated with asthma. Then, with adequate evidence, we categorize them into broad 4 categories, as I explained earlier: demographic, socioeconomic, environmental, and treatment-associated risk factors. Under those 4 domains, we assessed 32 risk factors associated with asthma, and few of them are mentioned in the slide. And final part of our methodology was to assess the association between risk factors and asthma control. We did it using the chi-square test under the significance level of 0.05. So, little bit of data collection. So, this was an interview-administered questionnaire, and we collected data from all tertiary care hospitals in Kandy district, namely National Hospital Kandy, Teaching Hospital Peradeniya, and Sirimau Bandaranaike Specialized Children's Hospital Peradeniya. And we covered all pediatric wards and clinics there. So our sampling method was simple random sampling and sample size was 363. So now we are approaching the most interesting part of our research, the results. Yes, first I'll give a brief demographic introduction to our sample. So as you can see, our sample mainly consisted of school-going children, and out of that, in our sample, we could see a slight male predominance. So, the most vital part, asthma control. Regarding asthma control, in our study we found out that in our sample, 1/3 of the whole sample was having a poorly controlled asthma. So this is a concerning effect. And with regards to the associated risk factors, out of the 32 risk factors we assessed, we found out 5 risk factors to be significantly associated with poor asthma control. From the demographic domain, we found out that allergic rhinitis is significantly associated with poor control asthma. Then under socioeconomic domain, unable to meet general physician or buy medications due to cost was significantly associated with poor control of asthma. Then under environmental risk factor domain, with the p-value of 0.001, we found out that if pets are allowed into child's bedroom, this is not merely talking about pets being reared in the house. If the pets are allowed into child's bedroom, it was significantly associated with poor asthma control. And next one, from the treatment associated risk factor domain, regular use of long-term medications. If it is not there, it means poor treatment compliance and unsatisfactory inhaler technique were significantly found to be associated with poor asthma control with p-values of 0.001. And finally, an interesting thing, if the child is using a pressurized metered dose inhaler with a spacer, it was found to be significantly associated with good asthma control irrespective of the child's age. So, if I briefly summarize our findings, so out of our whole sample, 1/3 was having poorly controlled asthma and having allergic rhinitis, the financial difficulties, and allowing patients enter into the child's bedroom, and the poor treatment compliance and unsatisfactory inhaler technique were found to be significantly associated with poorly controlled asthma, while if a child uses pressurized metered dose inhaler with a spacer device, found to be significantly associated with good controlled asthma. So the limitation-wise, if we were provided with the facilities for sensitization checking by allergy skin test for the environmental risk factors to be assessed, then our outcome would be much better. So the future directions of our study, we would intend to expand this study island-wide to have the big picture of the country, and we pointed out several modifiable risk factors associated with asthma in our study. To tackle those problems, we have few suggestions to be made. So first one, to address the drug shortages in government hospitals, to improve the transportation facilities to those hospitals, and to strengthen the health education to further improve the control that's being pediatric patients, and finally, to encourage the observation of patients' inhaler technique time to time by a healthcare professional, at least even at the commencement of the treatment would be helpful. So those are our references, and our heartfelt acknowledgements go to all those mentioned in this slide, including our Madam Supervisor, and thank you very much.
So, did you find any similar studies in your literature survey, etc.?
No, sir. That was one of the facts we were compelled to involve in this study, because in Sri Lanka, the studies regarding prevalence of asthma have been done, but lesser amount of studies. Especially if we regard the Kandy district, the number of studies were very much less. And here we were talking about not only the prevalence, we were talking about the level of asthma control and associated risk factors. Such kind of study we could not find anywhere.
So what was the age range of your sample?
Yes, sir. The questionnaire we used to assess asthma control, the childhood asthma control test, CACT, I demonstrated there, it was validated for the usage of children in the age group of 4 to 11. So we chose children from those age groups.
Yeah, so there were, in your question, you had 4 questions to be asked from the child. So was the 4-year-old child, was he able or she able to answer those questions?
Most of the time the child was able to, sir, because one aspect, the nature of the questions we asked. The first one was, how is your cough today? How is your asthma today? Do you often cough due to asthma? Those kind of questions, I think 4-year-old child maybe, somewhat maybe, but we found a difficulty.
Right. And who was collecting data? Is from your research team, or were there anyone else involved?
No, only we five.
So you had sort of few weeks, 2 weeks, and so only the admitted patients to the ward with asthma was involved in the study.
No, sir, the patients who were coming for the clinics were also involved.
Also involved. And so the inhaler technique, was it checked by the now, inhaler technique was one part on your control risk factors, no? So was it checked by the team, or was it asked from the patient?
In the ward setup, we could check because the patients were having the inhalers with them. In the clinic setup, it could be done because most of the patients were not bringing the inhaler devices to the clinic. No?
So how did you tick that box then?
Our supervisor was child asthma and immunity specialist, so she provided us with the inhaler devices. So we brought them to the clinics and asked them to demonstrate the technique.
Right.
One question. So, inhaler technique with using a spacer device was associated with good control. Any other factors that you identified in the people who had good control other than the inhaler technique? Anything else that was associated with good control?
That was the only findings. Thank you.
Thank you. We kindly request the speaker to please remain on stage to receive the certificates from our judges. We cordially invite Dr. Kaushika Gunasekara to award the certificate. Thank you very much, sir. Now we cordially invite Dr. Krishna Pradeep to present the rest of the certificates. We kindly request the remaining presenters to join us on stage in speaker order to receive their certificates. Thank you very much, sir.
And that concludes the second session of oral presentations of PEMSAG 24. We would like to extend our gratitude to our chairperson and judge for overseeing an excellent session. Thus, we cordially invite Dr. Tilanka Selviratna, consultant pediatrician, to come up on stage along with our session's chairperson and judge to award the certificates. Thank you very much. We will now behind our third parallel session of oral presentations in a few moments.